medcram.com.
You've got COVID-19 and you're in the hospital. Or you know somebody that's in the hospital and you want to be able to ask the right questions. Or maybe you just want to know what goes on behind those closed doors. Well, this is the video for you if you want to know everything that goes on that you wanted to know and some of the stuff that maybe you didn't. Welcome to another MedCram COVID-19 update. The first thing that we have to talk about are the different zones of the hospital. So there is the emergency room, there is the floor, and then there is the intensive care unit. Now, in the emergency room, technically that's not being admitted to the hospital. Here, you're being evaluated by the emergency room physician, and that is the one that is in charge of your care. The ER physician is going to make a determination about whether or not you should be admitted to the hospital, either to the floor or to the intensive care unit. And generally speaking, the question mark about whether or not you will be sent, quote, upstairs and go through the emergency room upstairs to the second floor or third floor or whatever floor that is if you need, in the case of COVID-19, a significant amount of supplemental oxygen. If you do, you're going to be admitted. If you don't, then you'll be discharged from the emergency room with some sort of treatment plan. And that could be any one of the new treatment plans that have been given emergency use authorization. For instance, it could be monoclonal antibodies. And we've talked about some other oral medications, such as molnupiravir, fluvoxamine, or Paxlovid. All of those, however, at this time are very hard to get to because there is a diminishing supply of those medications. So I encourage you to look at our video on 10 tips for if you get COVID. That video has other tips that you can do to help boost or support your immune system and help fight COVID-19. However, getting back to whether or not you should be admitted or not, I have heard of situations in the emergency room where the patient only needs a small amount of oxygen, and we'll talk about how much oxygen is small, but sometimes they can be set up with home oxygen and sent back home again. That is a potential option, but it's not one that's done regularly unless there are no beds available in the hospital. So generally speaking, if you need to be admitted to the hospital and you need supplemental oxygen, then you're generally going to be admitted to the floor. The only alternative to that is if you need to be admitted to the intensive care unit, and in that case, you would need to be on a ventilator, generally speaking. Now, just to fill in this chart, this hospital system is very complex. Because when the patient gets admitted from the emergency room, the ER physician is no longer in charge, but rather whoever service the patient is being admitted to. So if it's to the floor, the patient is most likely going to be admitted to what we call a hospitalist. This is a physician that is in charge of the patient while they're there in the hospital, unless, of course, they get admitted to the intensive care unit, and then the intensivist is in charge. And for the last 20 plus years, I have been both an intensivist and also a hospitalist. Earlier on in my working days, but more recently I am generally an intensivist, so I've been working in this environment for a long time. The ER physician, the hospitalist, and the intensivist can sometimes have more than a dozen patients under their care, sometimes 15 or even 20 patients, depending on how busy the service is. And of course, we have nurses. We have nurses that work in the intensive care unit. We have nurses that work on the floor, and we have nurses that work in the emergency room. And there are certain ratios that typically are followed in these situations, although it's not 100% the same across the board. In the emergency room, there are generally 4 patients to 1 nurse. On the floor, there are generally 4 or even sometimes 3 patients for 1 nurse. And in the intensive care unit, there are generally only 2 patients per nurse, and that's because of the acuity of these patients in the intensive care unit. But if you think hospitals run off of just doctors and nurses, I have another thing for you. In addition to these doctors, we have consultants. And these could be kidney doctors or GI doctors or cardiologists or infectious disease specialists. All of these are being asked to see certain patients by these treating physicians depending on the needs of their patients. There are also nurse practitioners and physician assistants. These are healthcare professionals that work alongside physicians and also provide care to the patients. But we're not done yet. There are also respiratory therapists. These are providers that can sometimes intubate patients or draw blood gases or provide treatments that are very important in COVID-19. We also have physical therapists. We have speech pathologists. Physical therapists make sure that the patients have good range of motion while they're in bed, and so they can help you or your loved one to make sure that when the time is to come home, that they're not deconditioned. Speech pathologists make sure that patients can swallow effectively and not aspirate. We have dietitians. These are professionals that make sure that the patients are getting the right kind of diet. Pharmacists. These are the providers that make sure that the antibiotics are the right dose, that there are no drug interactions, etc., making sure things are dosed correctly. We have social workers. Let's say you have things or papers that you need to have filled out by a physician. Social workers can help in this regard. What about making sure that the right people are signing the right kind of documents, or trying to sort out who's the one that needs to make medical decisions? Social workers help in this regard, and many other areas. Case managers, making sure that if there is extended care or the patient needs to be transferred out, that the appropriate paperwork and documentation is included, among other things. We also have chaplains, radiology techs, people that come around in the intensive care unit and other places that make sure that the chest x-rays are done on a daily basis, that the ultrasounds are done when they are asked for. Laboratory, people that go around and draw blood from patients, making sure that specimens are taken down at the right time. All of these things have to work appropriately. And of course, all of this creates a mess. And so where would we be if we didn't have janitorial or housekeeping? So you can see this is a very complicated system, and it needs to work smoothly if we are trying to get to the goal, which is to make the patient better. So if you're calling in, the best person to really talk to is the nurse. And it's because the nurse knows better than anyone else exactly what's happening to the patient, and it's because that nurse is next to that patient on a minute-by-minute basis throughout the day, updating the physician or other healthcare provider. If there are major changes in plan of care, it's also good to talk to the physician, as the physician will probably be talking to the family member or the patient themselves to make sure that they have consent for any other procedures or change of care that's going to be happening that day. Now, as you can see, these providers are very busy, and so it's advised that if there is one person in a family that can be the contact person to disseminate information, that will cut down on the amount of calls and allow the providers to do their job. Prior to the pandemic, we would have family members come into the hospital and join us on rounds to make sure that they were included. But in some floors and in some hospitals, it's difficult to do this because of policy secondary to transmission of the virus. So obviously, a move in an upward direction is representing a decline in status. So going from the emergency room to the floor is not a good sign, and going from the floor to the ICU is not a good sign. However, the opposite is a good sign. So going from the ICU back to the floor means that the current status is stabilizing. And of course, from the floor, people are usually discharged home and don't go through the emergency room on the way out. What I want to talk about next are some of the questions to ask in terms of how your patient is doing, how your loved one is doing, and some of the lab results and ventilator settings that can tell you a lot about how you or your loved one is doing in the hospital. So what we've done here is we've listed the different ways that we can deliver oxygen to the patient, starting at the bottom here with room air, which of course is no oxygen, and working our way all the way up to the top, which is the ventilator, which is exclusively used only in the intensive care unit. The reason why there's so many different ways of delivering oxygen is because each device is designed specifically to give increasing amounts of flow. Realize that the amount of flow going into your lungs changes second by second. Sometimes you're breathing out. Other times you're breathing in. Of course, when you're breathing in, the flow rate needs to be very high. And when you're breathing out, the flow rate is actually reversed. And so as we go up the list here, each device is more and more able to deliver high amounts of oxygen when the patient is breathing in. These flow rates are measured in liters per minute. So obviously, in terms of liters per minute, room air is 0 liters per minute. But a nasal cannula can be anywhere between 1 and 5 liters per minute. Of course, that is a reasonable amount of oxygen, but it's far less than you can breathe in. So therefore, when you're breathing in, you're not going to be breathing in just pure oxygen. You're going to be breathing in a mixture of the oxygen that's coming out of the nasal cannula and also the room air around. And this is what a nasal cannula looks like. So how much oxygen is that giving us? If we look at the FiO2, which is the fraction of inspired oxygen, and room air, it's 21%. That's how much by volume oxygen we're breathing in when we're not on oxygen. And for every liter, it's about 4% increase from there. So at 5 liters, we would be breathing in around 41% oxygen. In terms of an oxy mask, that can give up to about 15 liters. And generally, it can give between 40 and 60% FiO2. If you look at some of the data for oxy mask, you can see that the fraction of inspired oxygen can go anywhere from 24% up to 90%. But generally, we'll use the oxy mask in that mid-range clinically. And the oxy mask allows air to be mixed in with the oxygen to give a certain FiO2 depending on the amount of oxygen that's coming through as a liter flow. The next step up is something called a non-rebreather, and that can be anywhere from 10 to 15 liters of flow, and that would give you anywhere between 70 and 100% FiO2. And the reason why we're able to get 100% here is because there's a reservoir or a bag that fills up with oxygen while the patient is breathing out, so that when they breathe in, there's a reservoir of pure oxygen for them to breathe in on their next breath in. And perhaps you're wondering, why would we need anything more than a non-rebreather if it gives us 100% oxygen? Well, a non-rebreather mask simply is just a reservoir that allows oxygen to go in, but it doesn't actually assist the patient in breathing. It doesn't help them breathe. It's not pushing air into their lungs actively. This is for passive inhalation. The patient is doing 100% of the work. And you can see the reservoir here in this picture for this non-rebreather mask. A high-flow nasal cannula, or high flow as we call it, can go up to 70, that's 70 liters. And you can range anywhere from as low as 40% or even lower in some cases to 100%. And as you can imagine, that amount of flow can actually dry out the airway, and so it's usually humidified. And actually, we have a lot of our critical patients on high flow oxygen that are on the floor or that are getting worse on the floor. And as you can see here, 70 liters per minute of oxygen is a tremendous amount of oxygen, and you can see why treating COVID-19 patients uses up a lot of oxygen. And here you can see what a picture of high-flow oxygen looks like in an article titled, "Does High-Flow Oxygen Improve Outcomes in COVID Patients?" It showed that there are randomized trials that have actually shown that the use of high-flow oxygen was associated with less of a need for mechanical ventilation and a shorter time to recovery compared with conventional oxygen therapy in patients with severe COVID-19. As you can see here, the flow is very high and it needs a larger caliber tube to be able to pump that oxygen into the nose. A step above high flow is BiPAP, and this is where we're actually getting into something called non-invasive ventilation, because instead of just supplying the patient with higher amounts of oxygen, we're actually helping the air go in and come out of the patient using a tight sealing mask that fits around the patient's mouth and nose. And so what BiPAP does is it allows the air that's going in and out to be controlled and to be pressurized. So we're not really dealing with flow rates at this point with BiPAP. We're actually dialing in volumes. In other words, how many liters specifically are going to go into the patient, or more specifically, how many milliliters? Is it 400 milliliters each breath, 500 milliliters, or in BiPAP terminologies, what's the pressure that we're going to set the machine at? Are we going to be setting it at 15 or 12 centimeters of water pressure? And of course, with BiPAP, we can actually adjust this anywhere from 21% in most models up to 100%. The key here to understanding this, however, is when you get to BiPAP, it means now the patient is no longer able to support ventilation on their own, that they're needing external assistance with some sort of a mechanical device. And so it's these patients that are on BiPAP and not doing well that we start to look at from an intensive care standpoint as candidates that might need to be bumped up to the ICU to be watched more carefully or maybe even to be ventilated. And here is somebody on BiPAP. You can see that there is an actual machine that is pumping gas in and allowing it to come out at certain pressures, and that there is a seal around the mouth, and we are controlling the volume that's going in and out based on pressure. And of course, we can set how much oxygen is going into this volume with a dial, and we can adjust that to any sort of percentage. So finally, we get to the ventilator. And again, no flow rates, but we are usually controlling them based on volume. But you can adjust this based on pressure control. And that means that you can adjust how much air goes into the person based on the pressure. So you, in other words, ventilate somebody up to certain pressure and then let the air out. Or you could simply dial in the ventilator volumes, and that can go in and out as well. And for those that are interested, we have a whole series on ventilator settings and how to ventilate patients and the basics of ventilation. And since the pandemic, that was a paid course that we've made free of charge to educate people on how ventilators work. And of course, the FiO2 can be adjusted anywhere between 21 and 100%. So the course of many patients is they come into the hospital and they may get worse initially, stabilize, and then get better. Some patients get a lot worse before they get better. And of course, some patients get worse all the way to needing ventilation. And some of them never get off the ventilator, and others do get off the ventilator and then finally go home. They may require nasal cannula or oxygenation as an outpatient before discarding it. And so I make this chart so you can ask when you call in, or if you are a patient, so you know where you are in this scale and how you might be progressing or not in the scale of supplemental oxygen and ventilation. So an important question to ask is, what is the FiO2? Obviously, if the FiO2 is high, then that means that we're in a worse situation than if it is low. Realize that these numbers can bump around depending on the condition of the patient, and it's not a totally smooth course. I want to talk a little bit more about this transition of going from BiPAP to the ventilator. Obviously, this is a traumatic step, both emotionally and could be physically as well. Patients are on high settings on the BiPAP machine on the floor, and I'll typically get a call from the hospitalist as the intensivist on service saying that Mr. Smith is not doing well. His respiratory rate is very high. He's not able to keep up with ventilation anymore. His oxygenation is falling consistently down into the 80s or even lower into the 70s. And they believe that it's time to intubate the patient. Typically what we'll do is call the family, let them know that this is the situation. If we have time, we'll often allow them to FaceTime or to call in to talk to them before we do that, because when we put the tube down into the lungs, the patient is not going to be able to speak after that. He may be able to motion or write, depending on how deep the sedation is eventually. But when we go to intubate somebody, we are typically going to give them sedatives to make sure that they get knocked out when we put that tube down, because it's not a comfortable situation. The endotracheal tube is this tube here that we put down into the trachea. As you can see here, there's an inflatable balloon that we inflate to make sure that air stays in the lungs and doesn't leak around. This balloon also serves as protection of the airways to make sure that secretions don't go down and cause pneumonia. We use a blade such as seen here with a camera at the end of it so we can see the vocal cords, and then using the endotracheal tube we go down and place the tube between the vocal cords and then on down into the lungs at the appropriate position. Then inflate the balloon and continue to ventilate the patient. You can see, though, that there is a period of time where the patient stops breathing and we don't have the tube in place, and we have to get the tube in place, and there is at least 20 or 30 seconds where we're not ventilating the patient. So the team has to move efficiently, quickly, and successfully. Afterwards, you can see that the tube gets placed past the tongue, through the vocal cords, and then down into the lungs so that we can ventilate the patient. Endotracheal tubes can stay down there for at least a couple of weeks. Generally speaking, however, if the tube remains there for longer than 2 weeks, we start to see breakdown in the mouth because of the tube and the pressure that occurs. There can also be damage to the vocal cords and into the posterior aspect of the oropharynx. Because of this, if patients need to have endotracheal tube support from a ventilator, we usually switch to something called a tracheostomy. As you can see in this picture, a tracheostomy bypasses the upper airway and the tongue and the vocal cords and goes directly into the neck to supply oxygen and relieve carbon dioxide while either hooked up to a ventilator or open to room air. With the risks being that it's a minor surgical procedure, the benefit is that you can ventilate patients for much longer than 2 weeks and not have the consequences of tissue breakdown in the mouth. and it is the preferred method if patients want to convalesce or get better on a ventilator for more than 2 weeks. Okay, now I want to talk about what questions should one be asking if you are or a loved one is in the hospital. And the first one is there proning going on? This is by far the biggest way that families can help their loved ones in the hospital get better, is to make sure that their loved ones are proning. What is proning? It simply is lying on their stomachs. We did a video in January of 2020, literally when this was just starting, about the benefits of proning in ARDS, which is the primary way that COVID-19 kills. And the title of that video that we published on our channel was How Coronavirus Kills. And we'll put up the link there so you can see it. And in that video, we talked about the New England Journal of Medicine article that showed that proning in ARDS improved survival. And I'm telling you, as a critical care physician that has seen patients, I have seen where people have not been proning and they've been getting worse in terms of their oxygen requirements. And when we got serious about it and told them that, look, either they prone or they get put on the ventilator, once they understood what the real issues were and they proned, I saw turnarounds that avoided intubation. And sometimes it means that they stay on their belly for 24 hours if they have to. This is what needs to be done, because when we do this, what I see in patients is that the oxygen requirements come down in most cases to the point where we're able to at least delay intubation or even in some cases completely avoid it altogether. So if the patient is on the floor and they're able to tolerate it, sometimes they can't tolerate it because of blood pressure, but if they're able to tolerate it, they really should be spending as much time as they possibly can on their bellies, as if their life depended on it, because it very well may. For patients in the intensive care unit who are on the ventilator, that is a little bit more tricky, but even in those patients, we should be proning. And in fact, there's an equation that I use in the intensive care unit, and it's something called the PaO2, which is the partial pressure of oxygen in the arterial blood. And you get that off of something called an arterial blood gas. So you fill that number in there, and you divide it by what we talked about before, which is the FiO2. And the FiO2 is put in here as a decimal, so 70% would be 0.70. And you multiply that by 10 here in the numerator and the PEEP in the denominator. What's the PEEP? Another question that you should be asking when you're talking to your healthcare provider. PEEP is a setting that we put on the ventilator. It's the amount of pressure that is left in the circuit after the patient exhales. Why would you want pressure in the circuit after the patient exhales? You'd want that because that keeps the alveoli, which are these small pockets where gas exchange occurs. If you keep them open, you're able to do more gas exchange. So you type in the PaO2 off the blood gas, you type in the FiO2 off the ventilator, and then you multiply it by this ratio of 10 divided by the PEEP, and you'll get a number. If the number is less than 150, that's usually not a good sign. I highly recommend that patients prone in that situation. If the number is greater than 150 and they're on the ventilator, then you probably don't need to prone them. You can keep them supine. That's kind of a range that we're using in our hospital. It may be different in your hospital. So ask the doctor in charge, are you proning? And if so, great. And if not, why not? And obviously what we just talked about there is you're going to want to know what the FiO2 is, and you want that number to be going down if possible, as we just talked about. And then the PEEP is also a number that you want to actually be having go down as well, because high PEEP levels means that you're having to put a lot of pressure on those alveoli to keep them open. Now, there's a drawback to those high levels of PEEP, and that is sometimes you can get lung collapse or blown lungs, what we call pneumothorax. So the second thing or questions is, has there been a chest x-ray recently, and are you noticing air where air should not be? Sometimes when you put people on the ventilator or on BiPAP, and we're noticing this more and more in patients with COVID-19, is we'll see air under their skin around their neck. That's called subcutaneous emphysema. We'll also see air around their heart. That's called pneumomediastinum. And we'll see air around their lungs. That's called a pneumothorax. And if you start to see air where air should not be, that can cause problems. Obviously, if there's something called a pneumothorax, you'll need to put in a chest tube to evacuate that air. Otherwise, it could be fatal. And here's what I'm talking about. If you've got a endotracheal tube going down into the trachea, pushing air, and there happens to be a hole, in this case, in this lung right here, the air is going to escape into the chest cavity and keep building up breath by breath until this whole side is under so much pressure that this lung here gets crushed and the heart gets crushed as well, so that no blood can fill it. And if no blood can fill the heart, the blood pressure becomes very low. And this is called a tension pneumothorax, which is something that can happen when someone is on a ventilator. And the solution is to put a chest tube into here and to evacuate that air so that this doesn't happen. The first step, of course, would be to initially decompress this and allow the air to escape out so that they're not compressing the heart, and then to put in a formal chest tube to evacuate all the air to allow this lung to re-expand. The risk of this becomes larger and larger as the PEEP levels go higher and higher. Typical PEEP levels would be around 10 to 12 for most patients on the ventilator with COVID-19, but I have placed patients, because I needed to, up to a PEEP of even 24 because the patient saturation was dropping and the family understood that unless we did that, the patient wasn't going to make it. Another question that probably should be asked on a routine basis is checking the kidney function. And for that, we look at something called the creatinine. And generally speaking, if the creatinine in the patient is less than 1.0, then the kidney function should be generally okay. If it is greater than 1.5, that's a sign that we're having some issues with kidney function. And of course, it depends on the baseline as well. But in patients with COVID-19, we see many patients in the intensive care unit whose kidneys start to fail, and that requires hemodialysis. And generally, along with kidney failure is we'll start to see elevated potassium levels. So that's something to sometimes ask about as well, especially if there is acute kidney failure. Now, there are a number of markers that we often use in the setting of COVID-19 admission, not just in the intensive care unit, but also on the floor. And those markers can be helpful in determining whether or not the patient's improving or getting worse. The three markers that probably are looked at the most are something called the ferritin. And even though ferritin is associated with iron, in this case, it's also something called an acute phase protein, meaning that it goes up and down with inflammation. And what we want to see is the ferritin levels going down. If we start to see ferritin levels going down, then that means we're reducing inflammation. Another one is CRP, that's C-reactive protein. Again, even though the numbers generally are smaller than ferritin, we also want to see those numbers going down. And finally, the other one is a D-dimer. We also want to see those numbers go down as well. D-dimer is a protein that we detect in the blood whenever there is coagulation occurring. Now, we know from autopsies that people with COVID-19 pneumonia have 9 times the rate of blood clots in their lungs than do normal people who don't have COVID-19. And so we know that in COVID-19, blood clotting is a major, major issue. If we start to see the D-dimer go up, we're concerned that that might be going on, and your physician may have thoughts about whether or not to anticoagulate or not. That means to put the patient on a blood thinner. Now, there's been some data that's come out now, it's about a year old, that seems to indicate that patients who are in the intensive care unit or admitted to the intensive care unit don't seem to respond well to full dose anticoagulation, whereas patients who are admitted to the floor in less acute situations do respond to full dose anticoagulation. But again, this is a science that has not been completely fleshed out. Obviously, if the patient has documented blood clots either in the legs or in the lung, which is common in COVID-19, unfortunately, then we want to be using full-dose anticoagulation in the patient unless there's a contraindication. So it would be good if you wanted to keep track of how things are going to check the ferritin levels, the CRP, and the D-dimer when you call in and ask the nurse what they are so that you can find out if things are going in the right direction or in the wrong direction. Another thing to ask about is the white blood cell count. Many patients who are admitted to the intensive care unit and also to the floor are being started on steroids. There was the UK recovery trial that showed that dexamethasone at 6 milligrams intravenously or orally times 10 days improved survival. A very inexpensive, already approved medication that showed survival in COVID-19 based on a very large trial that was funded and published. And this today really is the cornerstone of treatment for most patients in the hospital. Of course, there's other treatments that have come along as well, but this is the major treatment course. And with this comes, generally speaking, for no other particular reason, elevated white blood cell counts. Now, this is problematic because physicians use the white blood cell count as a marker for possible infection. And so it's hard to know whether or not in these patients with COVID-19, almost all of them are on dexamethasone, whether or not the elevated white counts are related to fever. and infectious causes, or whether it's just related to the dexamethasone. Generally speaking, these patients have an infectious disease specialist that is following them, and they make decisions about antibiotics and whether or not they're useful at this point. So, of course, every case is different, and they all have their idiosyncrasies and characteristics that are specific to them. But what I've laid out here is a very good basis for the understanding of what are some of the things that you can talk about and ask when your loved one is in the hospital and you want to get some basic information about generally how well are they doing with respect to COVID-19. I wanted to briefly talk about a discussion that almost certainly the physician or the healthcare provider is going to be having with you, either as the patient or as the loved one, about something called code status. You shouldn't feel nervous when this conversation comes up because really the hospitalist or whoever's admitting the patient should always have this discussion regardless of whether or not the patient is expected to make it. And the reason is that people's heart can stop at any time, and we don't have time to call people to figure out what needs to be done. Chest compressions need to be started immediately, and so we always need to have a documented code status on file. And so let me just briefly talk about what those are at this point. We have something known as full code, something known as modified code, something known as DNR, and something known as palliative care. Let me explain these in detail so that you can be educated on what it is that they're talking about. When someone is full code, that means that if their heart were to stop, or if they were to stop breathing, or if their heart were to go into a rhythm that would require shock, or if their blood pressure were to fall significantly so that the patient would need medication to get the blood pressure back up, all of those things could be done. So there would be CPR, which is chest compressions. There would also be intubation, which is what we just talked about in this video. There could be shock, if we had to shock someone's heart out and get it back into rhythm. And there could also be something called vasopressors. Vasopressors are very good at increasing someone's blood pressure if it's low. And these are medications that typically go through very large IVs that have to be placed by physicians or nurse practitioners or PAs into specific areas of the body. Shock is something that we do to get someone's heart out of a bad rhythm, otherwise the patient will die imminently. Intubation we've already talked about, and CPR is when the heart completely stops, and the only way we'll get the patient back is if we do chest compressions on the patient, and potentially that can break ribs. In the setting of COVID-19, realize that a lot of what we're doing in the intensive care unit is very effective, and we do these things because they are effective. If, despite everything that we're doing for the patient's heart were to stop, remember that CPR is only going to get the patient's heart started again and put back into the situation that it was before the heart stopped in the first place. So CPR and shock and these sorts of things are bridges, hopefully, to a better situation that will keep the heart going. In the setting of COVID-19, it's extremely unlikely that doing CPR, shock, or things of that nature are going to get the patient back in rhythm so that they can be eventually walking out of the hospital. And so oftentimes, healthcare providers who are taking care of patients will ask this question, and it's really a value judgment. We simply give our opinion about how likely it is for this to work, and we meld that together with the knowledge of the patient or the family about what they would have wanted in this sort of situation. The one complication with CPR, as I mentioned, is sometimes they can break ribs because we have to go up to 1 inch to 2 inches of compression. And so that can cause breakage of the ribs, which can cause puncturing of the lungs, which might require chest tubes to prevent that pneumothorax that we talked about before. A modified code is simply just any one of these things that we talked about. So you might say, you know what? He would not have wanted CPR. He would not have wanted intubation. And he would not have wanted shock. But vasopressors to keep the blood pressure up is okay. So no on the CPR, no on the intubation, no on the shock, but yes on the vasopressors. And so you can kind of like a la carte choose what it is that you would want to have done based on the situation that the patient is in. This is known as a modified code. DNR is where none of this is done. This is do not resuscitate. Now, this is very important to understand. When somebody is DNR, they also sometimes specify DNI, do not intubate, to be very specific if they want to make sure. But generally speaking, when they say DNR, you're not doing either of these two. This is when if the patient's heart were to stop, or if certain things were to happen, we would not go down and escalate care. DNR does not mean do not treat. In other words, antibiotics could still happen. Medications, they're okay. Current care is okay. This is often what we select for patients and their families. When patients come in, we discuss this. We say, look, let's do everything we possibly can. But if, despite everything that we're doing, the patient still continues to get worse and the heart stops, it means that what we're doing is just not working and we'll let that patient go. That's called DNR. But it's very important to understand that DNR does not mean that we're stopping the current care. We're continuing the current care, but in the event that something catastrophic happens, we'll let the patient go and not do CPR. Finally, palliative care is a situation sometimes where families come in and said, look, Mr. Smith has been on the ventilator now for 21 days or 14 days or a certain amount of days longer than we knew that he would ever want to be on this. We don't want him to suffer anymore. We want to simply transition our care to being comfort. So in other words, taking out the ventilator in a comfortable way, removing the vasopressors in a comfortable way. And that's called palliative care. And that's when we actually slowly, in a stepwise function, take people off of the ventilator because they would not have wanted it for this period of time, and the quality of life perhaps is not as good, or perhaps they'll never be able to get off the ventilator. And really at this point is when we take that support off, we add to it pain medications. Now, we were always adding pain meds, even back here, but you have to realize that when you add too much pain medications, you can make the blood pressure go down, and you can cause these adverse effects. Well, now in this situation, we're no longer worried about that. What we are worried about is making sure that their pain is completely taken care of and their anxiety is completely taken care of. And if the blood pressure falls, so be it. And if the heart rate goes down, so be it. And if the respiratory rate goes down, so be it. We're not doing it to cause that. It's sort of a secondary side effect that is unintentional. We remove the support that we are giving the patient, and whatever happens, happens. At least the patient is comfortable. If the patient continues to do well, and we've had those situations where the patient actually does okay, and they're able to be downgraded to a regular floor and continue their care. And sometimes, obviously, depending on how much support the patient needs, they go to demise very quickly. But at least their family knows that they are not suffering. So that's what palliative care is. And so obviously there is no locking in of any of these. You can choose whichever one you want, and you can always change your mind. But what they need to know is, given a situation where you're not able to be contacted, what is it that they are to do in that event until you can be contacted? That's the purpose for knowing what a code status is. So I hope this has been somewhat educational. The purpose of this video really was for people who have loved ones or themselves are in the hospital and what to expect. You know, part of the difficulty of going into the hospital is the unknown and not knowing how things work. And I hope that this video will give you a little bit more of an outline and make something that's very difficult just a little bit easier. Thank you for joining us.